what's great is that your presentation answered like lots of questions already. We do have one asked from somebody who's watching today that I want to ask. Go ahead and ask. And then I just did want to say to others of you that are in here, if you want to put a question in the question and answer box, and if you could try and make it relevant to today's topic, we'll be happy to try and get it in without going too far over our time limit. So Dr. Jayne, first question I want to ask you today from a patient is, can a person develop refractory disease after a long period of remission, for example, 5 to 10 years of remission? If yes, how frequently might that occur?
So I think the first point to say is we never discharge patients, and you can have patients who've been in remission for a long time with off drugs for a long time in whom the disease can return. And you're right, occasionally that disease can then be difficult to get on top of. So the short answer is yes. And as I showed in my diagram, any relapse really means you're going back to the beginning, trying to establish disease control.
Right. I was just thinking that same thing from what I was watching you. I was like, did I have refractory disease in my early 6 years of on and off remission and relapse, and then 9 years of remission? That was very interesting to think about it from that perspective. I've never heard that before. One of the questions. Go ahead.
Sorry, Kathy. I suppose what I was going to say, I mentioned the importance of trying to get to understand a patient's refractory as soon as possible, because it gets the physician thinking and it gets the physician reaching out for help. And that to me is the most important point about all of this.
Understood. One of the questions that we did get in advance that I've been particularly interested in asking you is about biologics. I read that this is from someone else. I read that biologics in refractory vasculitis, and it then gives a full text in a clinical trial. Can Dr. Jayne explain what is meant by biologics in a way that patients will understand? And has there been any new evidence that biologics are effective to treat refractory vasculitis?
Yeah, absolutely. I mean, essentially, we talk about drugs as being small molecules, which are drugs like aspirin, often drugs administered in tablets. And these are typically the older drugs, but some newer drugs are small molecules as well. And then we talk about biologics, and biologics tend to use the biology of antibodies to precisely target a drug to a particular part of the body. So by biologic, we mean we're using biology. And as I say, that's typically an antibody, which compared to where a small molecule is tiny, biologics tend to be huge, and they tend to be given by intravenous infusion or by injection. And at the end of the day, they're drugs. It's just a different way of developing drugs. But biologics tend to be targeted and tend to be safer because they don't have all these sort of so-called off-target effects that small molecules have. As far as the second part of the question, absolutely. So if a drug's name is long and ends with MAB, that's a biologic because that's a monoclonal antibody. That's what the MAB stands for. So Rituximab is a biologic. And yes, we use that for refractory disease. Tocilizumab is a biologic. And yes, we use that in GCA, both for new patients and refractory disease. But I think you should just regard them as another type of drug.
Okay, thank you. One other question from a patient. If I'm always ANCA and or MPO and or PR3 positive, even though I take Rituximab, prednisone, and more on a regular basis for many years, am I considered to have refractory vasculitis?
No. It's very important to differentiate what a test is telling you, as I said in my talk, from the overall impression that the disease is active. Just that the fact that your ANCA is positive does not mean you have active disease. ANCA is a blood test. It's very useful diagnostically. But once you've made the diagnosis, the utility of having a positive or negative ANCA becomes more complex. The simplest way of viewing it is you probably have a slightly higher risk of the disease returning if drugs are reduced if you're ANCA positive. It does not mean you're refractory.
Okay. This one might be similar to the one we did a few minutes ago. Do you see refractory disease related to the use of biosimilar generic versions of Rituxan?
Sure. So what biosimilars are simply a copycat. So when the pharmaceutical industry develops a drug, they have a period of patent protection, and the only drug you can get on the market is that drug company's drug. So, for example, for Rituximab, it was Rituxan, which was the Genentech drug. When that patent exclusivity goes, anyone can make a copycat, usually at a much cheaper price, and they're called biosimilars. They're never identical because it's impossible to make an identical biologic, but they're designed to be similar. My experience is the biosimilars are effective, but just my sort of streetwise comment is we tend to see slightly more in the way of side effects. That's not universal, and it's certainly not a message you shouldn't have biosimilars, because many people are perfectly happy on biosimilars. So I think my message is they work, but you may find you get a side effect when you didn't get a side effect on the original version.
Okay, thank you. Any evidence of avacopan on refractory but not most severe lung, kidney, ANCA vasculitis and ENT manifestations?
Yeah, so I mean, avacopan I touched on towards the end of the talk. It's an exciting new drug that's been developed for ANCA vasculitis and is available now, and we are using it for refractory patients. It was not formally tested in refractory patients. It was mainly formally tested in new patients in combination with either rituximab or cyclophosphamide. So that's where the best data is. But as I mentioned, inevitably, if you have a new drug, the patients you're going to go to are the ones with refractory disease, and we and others are using it. I don't want to say quite how effective it is in specific situations, because I think we simply don't have the volume of experience to be confident in saying it works for this or it doesn't work for that. But I think anyone with GPA or MPA who thinks they might be refractory, avacopan is going to be there to be discussed.
Okay. And could refractory vasculitis apply to Takayasu?
Yeah, it can apply to any vasculitis.
Right.
So Takayasu tends to affect larger arteries, particularly arteries supplying the arms, the brain, in younger patients. And absolutely a small group of Takayasu patients, you make the diagnosis, and these arteries get narrower and narrower and narrower, continue narrowing down despite treatment. Fortunately, it's not that common, a refractory Takayasu, but it can occur.
Another question we got is, I wondered if Dr. Jayne has ever treated a patient who would not respond to prednisone. If so, what other steroid option could be considered, or is that a spot to add avacopan?
Yeah, so often what happens with vasculitis is the patients start by being remarkably responsive to prednisone, and then progressively they become less sensitive to prednisone, and there are biological reasons for this, and that's why you sometimes get patients who say, "Oh, my vasculitis completely went away with steroids," and then 9 months later it comes back with a vengeance, and the steroids don't work very well. So one thing is the disease does become more resistant, but there are lots of other reasons why steroids may not work. Sometimes they're not absorbed properly. Sometimes they're not dosed correctly. I think the most common reason is patients just don't want to take them.
Right. So there's a comment in here on whether you think refractory can be an occurrence by age. Does refractory affect young patients or older patients more?
Paradoxically, I would say younger patients more. And although older patients can have really alarming vasculitis, can be very sick with vasculitis, older patients tend to be slightly more sensitive to medication and tend to be more treatment responsive. The downside of that is that older patients are at higher risk of side effects from the drugs as well. But the most refractory patients we have tend to be younger patients, and we're probably underdosing them a little bit, or they're breaking the drugs down really quite quickly. And we usually get there, but it can take longer. So age is relevant, but it's sort of more complex.
Okay. And this one's related to COVID, and it might seem like an odd question, but this person wants to know if is there any evidence that a GPA patient twice infected with COVID could develop refractory vasculitis because of COVID? Or asked another way, is it possible that COVID could interfere with a patient's tolerance of Rituxan?
Yeah, I mean, I think that's a fascinating question, and unfortunately, we've had a huge amount of experience because pretty well all of our patients have had COVID at one time or another. Basically, I don't think there's been a major impact. The major impact has been disruption of healthcare and patients not getting to their appointments and not getting their treatment. I'm perfectly prepared to accept, though, that there will be rare cases where COVID has really upset people and made their disease more difficult to treat. But looking at all of my service, the major problem with COVID has not been making the diseases harder to treat. It's been the disruption to healthcare.
Understood. And one final question. I wondered if, let's see, is it worth going back to a medication and trying it again in hopes that it may work a second time around, especially after Rituximab failure?
Yes, it can be. When I was sort of going through the checklists about refractory disease, I often, said about have we optimized the drugs, have we got the dose right? And we do sometimes go back to using the same drug again, but it's with some thought, and you have to sort of convince yourself you're probably going to do something different. Something's changed that might make it more likely to work. Fortunately, we don't have to do it anything like as much as we used to do it. We used to do it much more because we were so limited with our drug choices.
Okay, well, I thank you. I'm sorry we didn't get to absolutely everybody's question. We tried to pick the ones that were specifically related to refractory vasculitis. I know that a lot of you do have other questions, and I hope that we will get to them in other vasculitis webinars. And having said all that, as I said, I'm afraid we've run out of time for today, but thank you to Dr. Jayne for educating all of us about refractory vasculitis. I feel like your presentation was fascinating and did that. And we appreciate you giving up some of your time today to have this conversation with patients who are watching today. We also would like to thank the Vasculitis Foundation for hosting this important educational video series. And just saying that, there are a few great ways to stay informed about vasculitis. One of them is if you go to the Vasculitis Foundation website, you can subscribe to e-news. Every month, the VF publishes an electronic newsletter. So that's a great way to stay on top of things. And maybe the best advice is to visit the Vasculitis Foundation website to learn more about the foundation on its own. The website has information on different types of vasculitis, which is what we're all asking questions about. Also, it has a Find a Doctor tab, which I love. I refer people to that all the time. And today's webinar, just like all the other webinars that were recorded, will show up on the Vasculitis Foundation website, usually about 5 days to a week afterwards, depending on how many other webinars we do that week. But Dr. Jayne, thank you so much. We really, really appreciate your time. And I hope I'm speaking for all of those out there. I see some people clapping. So thank you so much for sharing your time with us today.
So Kathy, thanks very much. I've enjoyed it.
Okay, goodbye, everybody.